My name is John Bannon. I live in Portmarnock, County Dublin. I'm living here for the past 16 years.
My name is Anne. I'm from Drimna and I met JB 6 years ago.
My name is Jennifer. I'm from Airfield in Dublin and JB is my dad.
In 2004, I was having a pint and I was starting to tap my hands, as you do, on the bar. And I found I couldn't tap it. I couldn't do my fingers were sort of locked. I think that was strange. And over the next sort of few weeks, it was playing in my mind, and I said, I must get that checked out, because when I tried to do it, I couldn't. The dexterity was gone, and went to my GP. He sent me for a few tests, and then said, listen, we've got to go a little bit deeper into this, and sent me off to a neurologist. And within 6 months, I was diagnosed with Parkinson's. He has a massive big chart in his room, and all of the drugs associated with the treatment of Parkinson's are there. We started off at the lower end of the scale, and I would have got maybe 18 months out of that, and then we sort of ramped up a little bit more, introduced something else and took something out of it.
The oral route, particularly in Parkinson's disease where gastric emptying is a little bit inefficient, is suboptimal, and patients have tablets that often sit around and are not absorbed.
Like in the last couple of years, things got bad. Like his movement was quite bad, his speech was quite bad. A couple of times he could leave a message on the phone and I'd have to kind of listen a couple of times, or, you know, mid-conversation, it's only so many times you can say sorry, or, you know, like, I can't understand you. That was kind of hard for me because he's so young, and, you know, that was upsetting to see him go downhill like that so quick.
John was good when I met him. The Parkinson's was there, the tiredness was there that comes from the Parkinson's as well, but that was fine. And then 12 months, 18 months into the relationship, the cramps came.
I was getting cramps, and the cramps were starting to get really, really bad. And what happened was your feet used to close, your toes used to close up, your big toe would go under, and your foot would arch. The back of your leg here would tighten up in a muscle cramp, and your thigh would muscle into a cramp. It's like when you're a young guy playing football and somebody gave you a heart attack and you had a cramp in your leg. Well, multiply that by, say, 100, and that's no exaggeration, that you'd actually think your leg's on a break.
Things got tough. They got tough on us. We couldn't plan to go out. He couldn't make any plans, because before you'd leave the apartment, he could get a cramp, and then it'd just have to be cancelled.
And over a period of time then, the cramping left me in a situation whereby practically every day, your legs were so sore, your whole demeanour changed, your way of standing, your way of walking. I felt I ended up sort of a shuffle. They're not the typical sort of shuffle. It was my legs were so sore, I couldn't actually bring my foot up from my heel to the ground and walk normally.
Yeah, his how he walked was quite bad. He'd kind of shuffle more than walk. The speech was a big thing. He wouldn't really smile. Like Anne mentioned, his personality was just kind of a bit more bland. You know, he wouldn't laugh as much, or he wouldn't joke as much.
And then over a period of time then my facial expressions would change. I would not only be a bubbly guy, laughing and joking and all that, but I found my smile went, that even though you were trying to smile, you couldn't.
He was going down. Depression, anxiety. You know, when is this going to happen to me? Will I make it to Dunstores to do me shopping? You know, that kind of stuff. It was just wearing him down.
We had sort of got to a stage where the medication was just about at the max, at the plateau. So there was various other more drastic type or advanced medication available to me. And the one that sprung out to me was the deep brain stimulation.
Patients with Parkinson's disease who are suitable for deep brain stimulation are less than 70 years of age, typically will have had more than 5 years of Parkinson's disease, and have emerged into a phase of their condition where they're typically taking multiple daily doses of levodopa.
The big thing would be major surgery. Your brain, the most important part of your body, the most important organ in your body, and now you have somebody going to drill, take a piece out of your skull, put a wire into your brain, cement an implant, 2 of them in fact, and feed wires back and have an implant in your chest. Scary stuff.
Of all the device-aided therapies we use, it is the most invasive. It requires a brain operation. And so patients who decide that they would like to hear more about DBS and be considered for DBS need to meet a neurosurgeon to discuss the very real and significant risks associated with having hardware placed within the brain. Those risks would be the risk of bleeding or a stroke during the procedure or infection in the perioperative period. Thankfully, neurosurgeons now have become hugely successful and skillful in placing DBS systems, and these risks are small, however can't be ignored.
But that versus the benefits of the actual operation itself, I wasn't prepared to have a disease or an ailment curtail my activities like that. And the only way I could do that was deep brain stimulation, and therefore I decided that's for me.
Deep brain stimulation uses electricity to mimic the effect of levodopa. Deep brain stimulation is not superior to levodopa, so the benefit patients get from their oral medication is not inferior to what they experience from the electrical stimulation that DBS delivers. However, of course, DBS delivers electricity over a 24-hour period, so it's reliable and consistent, and that's what these patients need, where their days become a roller coaster of on periods and off periods.
Yeah, it's scary, it's your brain obviously, but if I think I knew he'd be better than he was and anything was going to be better than he was.
We have to be absolutely certain that we're choosing the right patient when we're sending them towards neurosurgery, because to send a patient who is unlikely to get benefit would not be acceptable clearly. So there's quite a long workup required to build up the information we require to determine if a patient is a good candidate.
It probably took about 2.5 years to get from the initial thought of it to actually getting the actual operation done.
So we tend to bring patients in for a levodopa challenge to see how well they respond to a good dose of levodopa. They meet with our neuropsychologist to have quite in-depth cognitive testing over a number of hours on a day, or perhaps more than one day, to see to what degree there may be some thinking difficulty. We like to have speech and language therapy assessments done. One of the medium to long-term complications that some patients experience after DBS is change in speech and a loss in volume or clarity of speech. So it's important to have that assessed beforehand. So deep brain stimulation clearly requires hospitalisation. Most patients will have 1 or 2 pre-operative assessments with a neurosurgeon in the centre where they're having their surgery performed. And then the surgery itself tends to be performed over admission between 7 to 10 days long.
They did all the tests first of all on the Tuesday, and they marked out in my head where the little sort of cage was going to go to. So all the calculations are done in preparation for the operation on the Wednesday. So the Wednesday came and wheeled down to the anteroom. At about 3:20, the nurse who was looking after me, Caroline, came in, big smiles, and said, "You're on." Put on the stretcher, wheeled in, and the surgeon said to me, "Do you know what this is all about?" And I said, "Absolutely, 100%. Any questions?" "No." Put the line on my arm, and that was it.
The surgery is done either in an awake state with a local anaesthetic, which many patients find difficult to think about. Different centres have different approaches, and many centres have now moved towards a general anaesthetic approach where the leads are placed by the neurosurgeon under a general anaesthetic.
When you go for this operation, you're put on a normal gurney, the line is put in, and you get your general anaesthetic and you're gone. And they strap you in, and then they actually turn you around upside down, put you into the CAT scan, they do all the business.
In the immediate post-operative period, the placement of the leads that deliver the electricity actually creates a small hole, and many patients will have benefit with almost complete relief of their Parkinson's symptoms that may last days or weeks before the electricity is even turned on. It's not uncommon, therefore, for patients to be told to go home, stay on your usual medication, and come back when that post-operative so-called lesion effect wears off.
Towards the morning, I woke up back in the ward, and at about 7 o'clock that morning, the professor came in and tapped me on the shoulder and said, "John, you can go home today." And that was it. So I was gone by maybe 12 o'clock.
It was just great to see him coming through the operation, and just to see the brightness back in his face again and life back in him. It was instant. I couldn't believe it.
And there's actually 3 scars, one there, and one at the back. And a few holes then where the bolts went to your head.
They healed quite quickly on his head. The one on his chest where he has the little pacemaker took a bit longer to heal up. But his head healed up fine. He had got no infections or anything from it.
It is critical that patients take care of hygiene for the post-operative period, and on an ongoing basis, because infection is the main concern anytime you place any hardware within the body.
They give you a remote control unit that is 3.5 volts is the maximum amount of voltage that can come out of this, and it's split to your left side and your right side.
One of the beauties of deep brain stimulation is that it's a closed system, so unlike some of the pump-based therapies we used, there's no hardware for the patient to have to manipulate on a day-to-day basis. Some patients will be given leeway to manipulate the electricity either upwards or downwards depending on their symptoms. And all patients have a patient programmer where they can read their neurostimulation device to check the battery and to make sure it's on. Deep brain stimulation requires a placement of a battery that delivers electricity that produces the stimulation. Luckily now we have two options. We have rechargeable batteries and non-rechargeable batteries.
The battery in this one will last 3 years. So in theory, you have to go back the rest of every 3 years and get a new battery in that, which means opening the chest again and taking it out and putting a battery in. But the fact that I'm only on such a low dose of voltage coming out of it, they reckon it could be 10 years by the time I have to get any change of battery. My life was my life again. I was just back to where I was before Parkinson's ever came.
John has got his personality back, his sense of humour. He's a great sense of humour, but that was lost for a couple of years while the cramps took over. His face is much brighter.
He laughs, he jokes, he can walk the dogs, sense of humour is back. His movement, his posture, he stands up straight, he's just so sociable and nothing can stop him now.
My biggest probably problem was to realise I was 57, 58. I wasn't 37, 38, because I was walking fast. The girls were sort of saying, slow down, we can't keep up with you.
Initially when he came out of hospital, I had to tell him to slow down. I couldn't keep up with him. And I walk fast. I couldn't keep up with him. He was running around the place.
The only sort of side effect I really have is sort of around here, I've no feeling there at all. It's just sort of a dull feeling, and that's from the pulling of the wires and that sort of stuff. But it's nothing.
But it was the best thing that ever happened to John, to me, and to us.
Of all the device-aided therapies, DBS is probably the superior treatment when it comes to reducing dyskinesia and improving on time. The challenge, of course, is it's the most invasive of all the device-aided therapies, and that's the difficulty many patients have with making a decision to proceed to DBS. And
it's not a decision to be made lightly. And you can understand the fears of people, that they say, well, there's drills going into my brain and there's wires being put into it. But you gotta say, if I don't go down that road, what's going to be my quality of life in 2 years, 3 years, 4 years, 5 years down the line?
Your final result of DBS, when your procedure's done and when you're switched on and you're live with your voltage, outweighs anything else that you've gone through in your past, and you will have your life back. And it's all about getting your life back.
The dangers are far outweighed by the good effects, and they sort of pale into insignificance. You get your life back, you do things that you haven't done for years, and the peace of mind, simple things, the shower, walking my dogs in the park, driving the car, going to work, getting up in the mornings, not having aches and pains all over you, not worrying, am I going to fall in a heap in the ground, when is the cramps going to happen? It's too easy to go down the negative road. You know, what if? If we were to go down that right way all our life, what if? You'd never get anywhere.
Try not to be afraid, because it's completely changed all of our lives for the better. And I wouldn't worry about it whatsoever. Like, I have my dad back, he's completely back.